So those who don't know me, my name is Michael O'Reilly, and I work in the Department of Pediatrics. And before we start, I want to acknowledge the members of the steering committee who helped to organize today's event. It's Dan Croft from Medicine, Allison Elder from Environmental Medicine, Steve Jarosz from Medicine, Denise Hocking from Pharm Phys, Tom Mariani from Pediatrics, and Ashley Rakow from Environmental Medicine. And these people helped to identify our keynote speaker and organize today's event and select the best abstracts whose presentations we'll be hearing later today. I want to give a special thanks to Mrs. Lizzie Williams Velasquez, who helped create the flyers, sent out the emails, and obviously organized the abstracts and a million other things that made today's event possible. Thank you very much, Lizzie. As a reminder, our keynote lecture will be followed by a career development session and 6 short presentations by 2 postdocs, 2 pre-docs, and 2 staff members whose abstracts were selected among 31 submitted abstracts. So it's now my pleasure to introduce our keynote speaker, Dr. Anne Hilgendorff, who is visiting us virtually from Munich, Germany. I had the pleasure of meeting Anne several years ago when I was invited to participate in Munich's annual Lung Research Day. We co-authored a review together, and she invited me to return in 2018 to attend the Munich International Autumn School. And I encourage you to try to get to attend that. It was one of the most amazing and best experiences I've had, where they bring students and trainees from around predominantly Europe to learn different methods and whatnot and listen to lectures. So now I'm very happy to be able to introduce Anne to my friends and colleagues. Anne graduated from medical school at the University of Gießen in Germany. She completed an internship and residency in pediatrics, working with Professor Ludwig Gortner in Gießen, and then went on for a fellowship in neonatology, working with Professor Andreas Schulz at the Perinatal Center of the Ludwig Maximilians University in Großhadern, Munich. And then did a 2-year postdoctoral fellowship at the University in Stanford with Professor Blond and Marlene Rabinovich. I think it's here that she cemented her expertise in basic science neonatology, because it's my understanding she may be the first person and only person to successfully mechanically ventilate a newborn mouse. And in 2011, she started the leadership of an independent young investigator group at the Comprehensive Pneumonology Center in Helmholtz in Munich that she continues to lead today. Her group studies chronic neonatal lung disease and central nervous comorbidities in different preclinical experimental models in mice, and clinical settings with a unique cohort of preterm infants with and without chronic lung disease. Anne has also served as a member of the interim leadership group at the CPC, and she successfully implemented and directs the CPC bioarchive that overlooks the tissue and body fluid samples from a broad variety of adult and pediatric lung disease. Her longstanding interest in neonatology and post-discharge care for preterm and at-risk neonates lead to the foundation of a new comprehensive developmental care center that she is directing. Anne has authored more than 70 papers and reviews during her career. She's involved in peer reviewed, as example, by serving on the editorial board of Frontiers in Pulmonary Medicine. And she's mentored numerous graduate medical students. So in recognition of Anne's accomplishments to the field and being the speaker at our 12th annual Lung Research and Training Day, we'll be sending her an honor, this plaque, which I don't know if you're gonna see it here, sorry, but it's a plaque, there it is, as well as an honorarium. As soon as we can get this off into the mail. Today, Anne's presentation is called The Title of Finding Suitable, the Journey of Finding Suitable Biomarkers for Neonatal Chronic Lung Disease. And as a reminder, please post a question or mention that you have a question by posting in the chat box. Anne or I will call upon you to ask the question at the end of her presentation. Thank you. Thank you again, Anne, for coming to speak with us virtually. I really, really appreciate this.
Thank you, Michael. It was an absolute pleasure to have you in Munich. I can only extend this invitation to everyone. We would love to have you. And as I just said when we started, I'm happy to hop on the first plane that allows me to and go visit you in Rochester, real time, real life. It's my absolute pleasure to walk through a couple of slides and my distinct pleasure to meet with students later and hear about their journey through their own career and neonatology. And I was asked a while ago why actually I'm so resilient and still pursuing the neonate lung. And I think it's a magic, absolutely magic organ. I think the lung in itself is a magic organ, and being able to study that at the very beginning and knowing or trying to know what drives this development, I think is a real pleasure. Thank you for having me, and I will try to entertain you good enough so that this is a rewarding start in the day. I will start right away and try to pull together a couple of questions that I actually faced when trying to come up with new ideas together with the entire community, come up with new ideas of how to diagnose chronic lung disease emerging after premature birth and sometimes even after term birth. And there's a couple questions that crossed my path that I'm trying to share so that we may have maybe fruitful discussions. And I took the liberty to actually enclose a couple slides from our own work so that we can maybe use this as a platform to try to bounce around ideas of what we could do together in the coming years. I think it's a true journey finding a suitable biomarker, and I will try to say why. So this is Damon. He was actually, I saw him in my outpatient clinic. That's now a couple of years ago. And he died from a part of BPD that Michael and I just discussed when we were heading into the meeting of today. He died of sudden right heart failure, which maybe wasn't all that sudden, if we're honest, but he then died at the age of 5. He was the bravest patient I have known thus far. I think that the disease, we can maybe agree on that the disease is driven by a couple of lung function changes long term. And I have picked this very familiar graph just to outline this. And we really have only a very vague idea, I believe, of what second hits might be and what they're actually doing to lung function. And I would add the question, well, is FEV1 always the only or the best choice, or can we choose different parameters even to track long-term function? We know that the disease is facing severe remodeling of the matrix, and I think this is where the true memory effect lies when we're looking at the stem cell tryouts, where they try to repopularize the decellurized lungs, and where the matrix actually then defines the fate of these cells. And we can't really alter this. So we have to see that we actually do something better in the beginning. I think we all agree on that. And then in the lower right part here is a vessel that from another patient of mine, where I don't have to explain to students most of the time that this is severe pathology. And one can imagine that blood flow is altered in these cases. And then we share with adult lung diseases, we share a couple of factors that we all have studied on, and we still don't know what's going on, I believe. And I will try to get back to these factors at least partially. So this is what I think one has to keep in mind when getting started and trying to find a new biomarker or a new indicator of disease. And I actually tried to pull together the questions that come to my mind when trying to find a biomarker per se, and then especially in a BPD cohort of BPD infants. So how do we define BPD in a meaningful manner? I will try to address the complications there. I think we need to keep predictive power in mind. Of course, the clinical applicability. We don't want to use something that takes an hour for each resident every time when rechecking, what the risk is, or it takes even a larger amount of time, or isn't even feasible because the tools involved are not available everywhere. the international agreeability, and I apologize if some of the words may be a little bit have a German touch to it and that don't even exist in the English language. I think we can learn from adult pulmonary medicine. So what do the big guys do? What do other disciplines do? And for example, cystic fibrosis, I had an interesting conversation with a couple of people at Stanford the other day saying, well, why is cystic fibrosis doing so much better than we do in BPD? I think it's a fair question. How do we address the complexity of disease origin? So there is huge differences if we're talking disease induction by oxygen or mechanical ventilation. What are we doing with inflammation? And we're not even addressing the dose properly, I believe, especially in prenatal inflammatory circumstances. We're very limited with regard to animal models, I think, with true translational animal models. How do we address the complexity of comorbidity interplay? Are we really with this factor that we are addressing detecting lung disease, or are we detecting a comorbidity that is actually important there? And is one the predictor of the other, or the other way around? So the hen and egg problem. Which screening tool do we choose? And is every screening tool really really applicable and really useful? And always bearing in mind that we want to bring this to the clinic. And this is a problem that we were facing as well that I wanted to address. And which analysis tool do we choose? So the chronic challenge of low N numbers, at least here in Germany, with the preterm infants. And we either have larger N numbers, but then the deep phenotyping is not so, so great, or we do have deeply phenotyped children, but then the N numbers are considerably low. So I would like to start with the clinical definition and the limitations, of course. I'm going to show something that everybody knows by heart, back and forth. So we're talking about a disease that's defined by clinical parameters, and we're assessing them when the infant goes home. So that I think is something that remains a problem as well in the identification of therapeutic targets, because then we're buying in a lot of side effects, I believe, if we're treating the babies and we don't know really whom to treat and whom not to treat. And then of course we're treating everyone and having a lot of side effects there. We know that we're facing long-term consequences, and we know that we have severely limited treatment options here. So when you roam through the literature and try to find papers that are actually providing you with a standpoint of view that may be of added value as a clinician, and I pulled together a couple of pieces from the literature for this students and residents as well, then all of them conclude that really, we don't have that good of a marker yet. And opinions may vary, but the review papers at least always come to the conclusion that this really is what it is. External validation is sometimes a problem. And the overall problem is that there is poor predictive power with the clinical diagnosis per se, so that even from Canada, it was suggested to use oxygen dependency at 40 weeks. And so, we're trying to find a good test. The other day, I learned that the European network from adult lung fibrosis, they're using a test where they have the patient at home, Zoom applicable, so to say. They have them sit down and stand up, and that was that. And then they, that was the test. I thought, well, that's a pretty clever option, and we should maybe try to aim for that clinical test as well, because even running in some of the more disabled kids is a problem, as we know. And sometimes I feel that we should maybe piggyback on those endeavors that measure general movements and see that we can get more out of those videos that are now taken, because now it's clear that this is actually a good tool to predict neurologic development. We should maybe piggyback on those tools and say, well, you know, let's try to get breathing movements out of those videos that are sophisticatedly taken. If we look at prediction tools for BPD risk, then we do have the option that was published in 2011, where they have used a couple of clinical risk factors to try to help the clinician to predict BPD. At least in Europe, it's not very widely used, and I'm eager to learn if you're using this on your NICU. And then we're facing a problem, and this is studies from the Mosaic study that addressed European perinatal centers, and they only addressed the larger centers. And they saw that BPD varied across those centers widely across different European countries, and that it was highly depending on the care that was provided to the infant, as one can imagine. But this, I think, is as well limiting the tools, or at least giving us a certain notion of how these tools need to be designed. So the thoughts that I had and discussed in our group and here in Munich is, does a combination of markers, including early clinical, structural, and protein-based markers, does that really help? How can we make it clinically applicable? Can we define underlying disease subtypes? Do we have to? Or is the severity more the way to go? And should and can we consider pathophysiology? A quick detour, I thought that it might, at least it helped us to make a quick detour to adult pulmonary medicine, where I thought that the INMARK trial was actually something that that is worth looking at, where they tried to see in a clinical trial whether they were able to investigate changes in neoepitopes as predictors of disease progression under nintedanib treatment. They weren't able to do so. They could associate the nintedanib treatment to reduce decline in lung function, but they weren't able to really trace or show the success for the marker, though. I thought that this study done by Gisli Jenkins and colleagues was a very good example, though, to how this could be designed and what effort we might need to undertake to really be able to prove the usability of a marker in a larger cohort. We know, and this is just one of I think many examples. We know that the neonates are very specific with regard to their response to oxygen. So this is the adult response to oxygen, just displayed on this heat map after 2 and 8 hours of oxygen exposure. And here we do have the neonates, the control 2 and 8 hours, and then the oxygen 2 and 8 hours, and then the combination or the comparison that we only did in the neonates with regard to mechanical ventilation. If we look at these proteins and then check the proteins in tracheal aspirates and bronchoalveolar lavage fluid in deep proteomics, and compare adult patients and neonatal patients, we do see that difference, and we can recapitulate some of the markers that we have seen in the arrays here. And there's a couple of markers showing up here that do make a lot of sense, but that are differentially expressed when you compare them to the adult patient even. And amongst those, interestingly, was MUC5B, which I thought was interesting because this seems to be one of the markers emerging for adult lung disease. And maybe, well, I sometimes view it as a follow-up for BMPR2, which is another success story, but there's not too many. AFP certainly, I think, makes sense to be differentially expressed in the neonates, of course, but there's a couple of factors like collagen 6A1 that makes you wonder, why are these differentially expressed, although they're known to be differentially regulated in ILD, adult ILD patients. So this might be a perspective that's worth pursuing, and I know that Michael does wonderful work with his group to look at these long-term changes. And we just talked about the fact that this is really homework. It's tedious. It takes a long time, but I think this really needs to be done by people that know what they're looking at when they look at changes. With regard to making sense, I think the pathophysiologic perspective is important, and I think in pathophysiology we try to find that black sheep, that might be the only one in the herd, and then we can try to hunt this one down, try to make it white again, and then be good. We all know that this is not how it works. There's a lot of other black sheeps hiding in that herd, and we don't even know where they are, or they're not even born yet. So I think we really need to pay close attention. But I will try to elucidate a little bit what we think might be a couple of those black sheeps with regard to long-term effects as well, or with regard to making sense using them as an indicator. So neonate chronic lung disease, and this is really something that all of you know: reduced alveolarization, impaired vascularization, and the interaction between those two pillars of the disease. Pulmonary inflammation, altered signal transduction, and as I said earlier, the ECM remodeling that I think is a true effect that carries memory. Here we do know that pre and postnatal risk factors then drive the disease. And we haven't even really successfully addressed the topic of genetic susceptibility and immaturity. Well, we're starting at birth most of the time if we're talking babies, really. And there is a lot of history already to that organ. So we're trying to make a meaningful connection, and that might be inflammation, that might be matrix, that might be growth factors, and that might be signaling that stems from the microvessels, because it seems that all of these processes are tightly interconnected. And so if you find one good indicator there, or a couple of those, that you're really having your hands on talking about this process. So we know how it works when nothing disturbs the system. And then we know as soon as we're introducing postnatal injury, and again, there's already prenatal stress that was imposed on that lung. But if we're talking postnatal stress, then we're talking, I think, shear stress and oxygen toxicity. And now we're facing the problem that we have an influx of inflammatory cells. We do have a breakdown of the matrix. We don't know, is it a neutrophils? There's compelling work there as well. Is it the monocyte that comes in? Is it then the activated macrophage? And this guy is for sure secreting interesting products like MMPs and TGF, where as well adult medicine can show us the way. And then all the signaling that is related to the microvessels, as well as the epithelial cells, of course. So there's a couple of opportunities, and I think there were studies that have tried this, try to hunt down the inflammatory factors that might be the good predictors. And I think IL-1 beta is a very interesting one. And Saverio Belushi, I think, has published a very interesting chapter in the together with his colleagues in the new book for neonatal diseases, and he's talking about lung disease and about the impact that IL-1 beta has, TNF alpha, and IL-8. I think there is compelling evidence that this might be good factors as well long term. But The question always is how specific are they? And then we're diving into the problem of comorbidities and their detection. So I think there might be some limitation there. The degradation of elastin, I think that absolutely is something we could address if we're talking biomarkers. Then, of course, the secreted factors, that tells me that there's already some profound inflammatory changes going on and activation. And of course, we could address the microvessels. Something I had left out so far is the PDGF receptor alpha, my personal hobby, so to say. And I think that this is a nice protein because it's actually sitting on the verge, talking to the vessels, getting input, giving input to the matrix and getting input from the inflammatory cells. So I think that well, the people watching the door, so to say, might be interesting for therapy and might be interesting for disease indication as well. So when we're talking biomarkers, then we cannot only talk science or only talk clinics. We have to have the exchange. We need to know what the clinical spark is, and then it needs to be more than a spark. And then what I find so valuable in the States is that when you are going rounds, then there's people joining you from time to time that are already retired, and they give the input. And in Germany, that never happens. They're 65 and then they're, they have to go home. So so I think it's terrific that somebody then says, well, look, we've tried this 30 years ago and we weren't successful because A, B, C, and then the spark all of a sudden is that the spark, and that's that. So there's no fire behind it. But I think, talking it through in a larger group of people, then we can inform our preclinical models very well. But then we have to go back, we find something very exciting in the mouse, but then again, what does it tell us? So we have to validate it and have to see that we can get it applied. So in the preterm infant and in the neonatal mice, I think when we're talking biomarkers, we have to say, well, what body fluids are we addressing and why? Are they really easily accessible? And I showed you work from tracheal aspirates before when we compared this to the adult patients. But, we're aiming to ventilate less and less. And so, is there a future for the tracheal aspirate as a good body fluid? So then we're talking urine, but then the kidneys are very immature, and that is, to a varying degree. So how does that impact our biomarker? We do need lung function tests, and we do need that in the mice as well as in the preterm infants to say, well, can we compare this? So is it really a validated model? And then, of course, we can address the pathways in much more depth with the neonatal mice. Then we need to trim this down and say, well, mouse, nice, but then we cannot do everything in the mouse. And we need to have, I think, good in vitro model. And there's beautiful models out there. The organoids I'm not even touching. But as well, applying stretch, applying oxygen, we really need to carefully think, how many hours do we use? Do we really use 8 hours? Do we really use 24 hours? Why do we do that? What is the applicability to the clinic? And with regard to stretch, how many cycles do we use? Is that comparable to the preterm infant and the ventilation that this baby is seeing, or no? And I think this is something that we have to go through with the students, and especially when we derive data from these studies that we then want to use to spark an idea with regard to the biomarkers. Of course, oxygen will not leave us. This topic is, I think, an extremely interesting, and I think your group is one of the world leading experts in this. So I'm only trying to bring a little bit, regarding a question of completeness to the table here. I think we know that clinically we have shown that this is this oxygen saturation targeting is a huge topic. We still don't know what to go for. I think we have agreed on some, ranges with regard to saturation. But I think we will be redebating this as we go along for sure. So this is something that we have to consider when we as well look at a biomarker to say, well, is it driven by oxygen dependency? Is it really telling me oxygen days? Is it driven by oxygen, or is it predicting the dependency that is yet to come for the baby? And we know what neonatal hypoxia does, disrupting alveolar development in a severe way. And I think what we have talked about, as you can see here on the left, with the radioalveolar counts and the medial intercept. But what we have discussed, Michael and I, when we were joining in the Zoom meeting initially, is that the effects that are actually now more and more explored with regard to the cardiovascular system may be even more important long term, especially as I think we are underdiagnosing them severely. But now all the models that were used, or most of the models that were used initially, used high oxygen concentrations. And there's very few models that now trim the models down to these 40–50% that the babies are facing today. And I do believe that they do something very different. So when we're talking proliferation, when we're talking pushing cells to the edge, we're not getting rid of them by apoptosis, which we may be doing with 80%. But then we're having a cell that is maybe senescent, that is maybe has been senescent and is then stimulated again and is getting out of senescence and then proliferating. And I think, to my personal belief, I think that Andy Bush is right, saying that the airway response that we're seeing is due to the fact that we actually had airway cells, smooth muscle cells, etc., proliferate and provoke a phenotype that is long lasting, and that may be due to and that may be responsible for the wheezing that we see. And I know that. Michael, that your group has exciting data to come. So I think especially there, the double hit and triple hit, etc., is an interesting question. We know that if we look at the trachea, that this oxygen concentrations that are very modest can provoke inflammatory changes there. And this is not even the latest studies, but I think it's a very nicely done study and very comprehensively studied. If we're looking at biomarkers then and trying to get our head straight of what to do to find a good biomarker, then we have to, when we come from the topic of hypoxia, we have to consider the very different effects when comparing male and female subjects, be it patients or mice. And, the animal care committees are always disappointed because we're applying for even more mice. And then we need to kind of, do the experiments twice and address the male and the female mice. But I really think we need to do that. So either restrict ourselves to the male mice or the female for that matter. And we can really nicely see that how different that response to oxygen is if we're talking as well time dependency of the effect. So now when I joined Stanford, I virtually had no idea what I was getting myself into. And Dick Bland standing next to me always saying, quite a graveyard. This was everything he said when I started, and I started to put a trach in these mice under the microscope. And then he always said, well, I think there's still a lot of room for improvement. So that was his only words, and then he left. So this is how I spent my first weeks and months, and I can only encourage the students to just be resilient and persistent and just push through this. But I had a ticket back during my first month, always. This was my back door to escape. So it wasn't easy to get to know this technique and to really push it forward then towards treatment as well. I learned from Carlos Miller beautifully how to do lung mechanics, etc. But it's a tedious work, and it's like a neonatal care, intensive care unit. And then we as well set out to use stretching devices, use hypoxia, of course. I'm just showing this slide because I'm referring back to these two models when I show you a couple of data from our group now. As we have talked about the effects of hypoxia, I think we need to appreciate, and I know that there's other data out there as well, that very convincingly show it's not the same if you do hypoxia or if you do stretch, and it's not necessarily an additive effect if you do hypoxia and stretch or both, which I thought this would end up. I would see an array pattern that could then say, well, we're looking at hypoxia, then we're looking at stretch. That might do two different things, but then we have a severe injury and additive effect if we combine the two. But the effects were very different. Most surprisingly, this green thing that you see here, this is only time going by. So this is the effect that we have extrapolated by only letting 6 hours pass. So this is a developing lung, and it has a huge capacity to do things. And I think it's absolutely astounding if you look at these effects. And then we have a very distinct regulation if we look at mechanical ventilation only. If we look at mechanical ventilation and oxygen, we have a distinct regulation that is not necessarily shared to a large extent by hypoxia and or mechanical ventilation. So if we look at these different patterns, then we are just in the process of wrapping this up to take apart what the different pathways are. But it becomes complicated because there's not so much sharing than we thought it would be. And this is, I think, what we have to keep in mind, plus the fact that we have to think about long-term consequences, of course, and there's beautiful studies showing what oxygen is capable doing. I think the field that is ever more developing with regard to the epigenetics changes, I think will give us a lot of insight there. I just told Michael that the samples that we're wrapping up now, where we're looking at oxidative damage to the DNA, comparing adult and neonatal mice exposed as adults or exposed as neonates, and the group of neonates that were exposed as neonates as shortly as 8 hours and then followed up into adulthood, the response is very, very different. So I think we can learn from adult pulmonology as to how to do things, but I think with regard to the changes, we have to come up with our own concepts, it seems. As I said earlier, I think the platelet-derived growth factor receptor is a very valuable, or it might be a valuable tool because it sits on the edge and it's driving septation. It's significantly influenced when the lung is ventilated. There is a lot of apoptosis going on, and then there is a simultaneous downregulation of PDGF receptor alpha and its signaling, and together with, and we thought this might be associated with matrix remodeling, because this was my first thought that, as being the guy that, this myofibroblast being the guy that produces elastin at the septal tip. But it turns out that the VEGF-A production by these cells has a huge effect as well. And so it's actually talking to the microvessel. And thereby, I think targeting a cell or using that as an indicator that talks in different directions, be it matrix or be it the vessels, that might be of interest when we have our biomarker research be informed by pathway knowledge or by pathophysiologic changes. There is a bit of genetic background that comes into play that we were able to show by this GWAS study, and then by picking out single patients that had a very pronounced phenotype and showing that there is a little bit of background. We have just wrapped up a study with in a birth cohort where actually there was nothing there when we looked at the birth cohort with regard to PDGFR alpha. If we didn't account for second and third and fourth hits. If we do that, if we looked at smoke exposure, if we looked at air pollution exposure of these infants, then we could actually see that they had a more rapid decline in lung function and a lot more problems with regard to bronchitis and pneumonia when they had certain PDGFR alpha genotype in the background. But this can only be seen not in the regular GWAS way, but if you consider those second and third hits. We could rescue the phenotype back in the days. And this is where we thought this might be something worth pursuing. If we then add another level of complexity, we now challenge the mice with prenatal smoke exposure and then ventilated them or exposed them to oxygen. But smoke alone provoked a severe inflammatory reaction. So the monocyte comes back into play and again is talking to the microvessels, it seems, because we're having a lot of apoptosis going on in the endothelial cells. And that, of course, could be TGF-beta related, but that we haven't causally proven. And that goes together with the alveolar phenotype where septal density goes down. So I actually wanted to use the slide to say that we need elaborate models. So they cost money, they take time. But I think if we're talking the preterm infants, then we want to know there is some prenatal insult that we may not even know of, because it's, at least in Europe, it's, it's a very shameful thing to say, yes, I may have smoked one or the other cigarette. This exposure to prenatal smoke was not associated with growth retardation. Most of the models that are out there with prenatal smoke exposure do have an added level of complexity, because now the mice are growth retarded then when they're born, and then we don't know what we're talking about. So these were not growth retarded, but the smoke-related enzymes were regulated in the lungs of the neonates. And the lungs were severely altered with regard to inflammatory response and septal density, as well as vessels. Inflammatory changes have been shown in different studies, and I already said in the beginning, this is, of course, very interesting. And you can even say, well, at birth, when I want to divide BPD infants from no BPD, so this is no BPD and this is different degrees of BPD, then there is a certain type of monocyte activation that seems to have something to do with a CD14, CD16 phenotype that can already distinguish these babies at birth. So I think this gives hope that there's, terrific groups out there working on monocytes as well in the preterm infant and getting more and more the focus to the developmental responsibility of the monocyte in the lung as well, because I think it's as well needed to drive development. So this might be a good guide to trace down to see whether this can actually help us in making a decision. So this is done in umbilical cord blood. And this is the markers that are activated, confirmed on the protein level with the classical monocyte markers. And again, IL-1, in this regard, a different portion of IL-1 signaling, EGF, IL-8, TNF again, and the monocyte marker MCP1. There's other studies that have used the monocytes to distinguish and maybe get a hands on risk for BPD. And I included them here because I think maybe we want to distribute slides later, and the students could use that information. If we treat the mice with vitamin D prenatally, then we can alter that monocyte response. So here we can see that that when we look at a very early time point, then when we sufficiently supply them with vitamin D, then there is a slight increase that later will be significant if we expose them longer with oxygen. But if we do the same exposure in the vitamin D deficient mice that weren't really supplied with enough vitamin D during pregnancy, and I think one has to say worldwide, the mice are supplied with vitamin D up to here. That's, I think, common standard. So it's really tricky to get through with these models and say, well, what are we actually doing? Are we supplying them? Are we oversupplying them, or are we undersupplying them? But at least it's fair to say if we alter the levels, then we as well alter the inflammatory response. By using a TNF knockout mouse, we back in the days thought, well, that would be nice. Now targeting this TNF, and this is the TNF knockout that then shows when we expose them to mechanical ventilation, we're unleashing a TGF response. And this is what I learned during that study, because then the med student explained me, but that's logic, this is regulated via NF-kappa B, and this was to be expected. Well, I didn't expect it. And so, I had to learn it through talking to the student and addressing this mouse. So this makes it very challenging because we're talking a developing lung that has a certain balance of different growth factors. So if we're using one as a marker and then saying, well, that's the ultimate marker and that's true for each and every condition, that may not be true. With regard to screening and analysis tools, I think we're dealing with a couple of things. So we did a proteomic analysis, and I'm using these data to try to see what problems we were facing, because it's sometimes hard to do that for data that are published because they're also nice and polished. So I use our own data to take them apart and to tell you what didn't work and how hard this race was to try to find a biomarker, and still is. So we did SummaLogic. We used SummaLogic when I used this. When I started to do that, even SummaLogic had to trim down their assays to deal with these teeny tiny volumes that I was, that I was actually able to give them. So this is why they thought that's a nice challenge, and then they were able to do this. And then we did analysis over all the several hundred proteins, 1,129 to be exact. And then after accounting for gestational age, after accounting for inflammation, accounting for gender, etc., so all the different risk factors, these three candidates always popped back up. And by the courtesy of Dick Tibble and this group in Rotterdam, we were able to stain them in lung tissue and could see that they were Ziglag-14, a monocyte marker upregulated in BPD. BCAM, a matrix marker, upregulated in BPD and downregulated in the controls. And angiopoietin-like 3 vessel marker that is more known for liver diseases, was downregulated in the BPD lungs and upregulated in the control lungs. So I thought this was too good to be true. Now we had a marker that was accounting for inflammation, one for matrix, one for the vessels. So I told them we have to do the analysis again. We have to do the proteomics again, and we have to do the analysis again. And I wanted to, after briefly introducing the candidates, I wanted to elucidate what we try to do with regard to analysis to try to face the problems that I outlined earlier. Low N number. We have different platforms now because SummaLogic opted out and said, well, we're only doing business with the UK Biobank these days. And so we had to find a different platform. Now we wanted to combine these data sets, etc. So a couple of factors that we were facing while trying to chase these biomarkers. So cyclic 14 was actually shown in COPD to be a pretty good predictor of whether or not the patient was getting exacerbation during the course of disease. And so we thought, well, that could make sense, but there was only one report out there. But we know that the monocytes per se do make sense, and it has been shown in COPD and ILD that they are major players, as well as in BPD, as I told you earlier. So now we had collected 53 preterm infants, no BPD, mild BPD, moderate and severe BPD. We had done different runs with Zamologic. We had accounted and rerun aliquots, same aliquots on the different assays. And we had then switched to Olink proteomics because they were up and coming in the proteomic field. They were doing very nice work. They were promising us more and more panels as well. And the idea was to then at a certain point even be able to go away from chronic lung disease and look at other chronic lung diseases, maybe to create a pre-me chip. And we're currently trying to do that. But now we had these different platforms and these different modes of analysis. So first of all, we were trying to see, well, does the protein really bring something to the table? Because I mean, the clinical denominators, if you know the baby is very premature, if you know it has a severe infection, and if you know what gender it is, most of the neonatologists, including me, would say, well, anybody can say that will end up in BPD. So why do you need a protein? Cost money, and it's time consuming. So why bother doing it? So if we look at controls versus moderate and severe cases, and this is something that we learned over time, that we are provoking a more severe phenotype to learn something and then apply this on all the BPD cases, because I personally think that this mild BPD is always muddying the water and is really giving you troubles, because I think some belong in moderate and severe and some don't even have disease, maybe, or a very, very mild form. And so, I think they're making it very complicated. So here we looked at control and moderate and severe cases. And if you look at the AUC as a measure of how good we're separating, then we see that that if we're having the protein and gestational age, we're pretty good. If we're having the protein and gestational age and early onset infection, we're pretty good. If we include gender, we're pretty good, but the protein always seemed to play a role if we're considering the AUC, the area under the curve, as a measure of how good it separates or is capable to distinguish between classes. Then we looked at the AIC, and that is how well the model is actually fitting the data set that we're looking at, as you know. And so comparing different models, then again, we're trying to bring this down, this number down, and we see that if we're going downwards, then the protein starts to play a role, whereas above here we can do with only early onset infection and weight. That is a little different if we look at all the BPD cases, and I think this is telling you a story about what mild BPD does and how it influences what the biomarker chase is altered by when you look at these, because you see that yes, protein plays a role here too, but if you look at the AIC in more depth, then you see that the protein plays a role at a different level. So here already the protein does impact how good we were actually separating, whereas here this seems to be driven more by gestational age. And this is what we see in our MRI studies as well. And I will show you a classification tree later, that gestational age, the muddier it gets, so to say, is gestational age is a strong driver. But then again, if gestational age by itself would be good enough, we would all be doing this and not having an issue and just saying, well, you know, that's what it is. So to summarize, the proteins do add to it. And we had to prove this for the clinical study that we're now doing, to say, well, there is added value, so it does make sense. If we then look at the different grades, then of course, you know, we're losing some here in mild BPD, and I really question what these are, these babies. And so what we have then turned to is that we always tried to redo this by using mechanical ventilation days, oxygen supplementation days, or NICU stay as a marker of severity. And the markers, and I totally forgot to tell you, the markers were taken the first week of life. So this is very early. So this is predicting how many days of mechanical ventilation will be needed in the future, and oxygen days will be needed. And so this correlates very nicely as well with the severity. I think that we need to do this though, because the BPD classification per se, I think, is too broad. So we need to use the single and then count variables to be more precise. If we look at different platforms, I mean, we're by far not the only ones facing this problem. So there's this old story of batch correction. With regard to the three factors and Olink and SummerLogic and the different SummerLogic runs, we actually were able to find a strategy to do batch correction. And I think this is maybe important information if then we're trying to combine as well different data sets over the planet, because we're not having you know, thousands and thousands of babies, and we don't all have the money to run these proteomics all the time. So I think we need to find a way of how to combine data sets. The small data set without external validation sets are sometimes a problem. And we had a validation set, but if you don't have one, then what worked for us pretty well was a leave one out cross validation. And what we thought was necessary too, facing the clinical study, we needed to prove disease specificity. So we could show that COPD and IPF are very different, and we could show that as well with regard to chronic lung disease provoked by congenital diaphragmatic hernia. So the differentiation with the three proteins worked very well for BPD. As you can see in the dark line here, and didn't work as expected that well for the CDH infants. Single markers did though, but not the combination in the typical pattern that we used. So when you look at oxygen supplementation and you look at the markers separately, that as well you have to do, because if you're looking for a biomarker, you will be questioned for each and every dime, of course. You know, do you really need both of them or all the three of them? Can you do with one? Is one really driving the show? And we think that if you look at the overall correlation, then I think it does make sense to determine all the three. Clinically, I would say that it makes sense to me, having the suspicion that there's underlying phenotypes that we try to trace down or chase down all of them. And I think the likelihood is greater if we have more markers that we can combine. But as I showed earlier, the algorithm that we came up combined in this analysis here, combined as well the clinical markers. And I don't think that we should be better than the clinical marker. We should just team up and see that it works all together. I hope, Michael, I'm still in keeping with your time and your all all of your ability to still listen to this. If not, we can make a break and have questions already. Should I continue?
I don't know how much water you have. I mean,
so we will go into structural quantification, and then I think we're slowly heading out.
Maybe a quick statement on the structural kind of, you know, because I don't think that, I think that's pretty important stuff, you know, a couple minutes, a minute on that. Yeah.
Okay. So I think as well, going back to mice, I think we do have to be better than a clinical diagnosis. And I think structure is the way to go. It, I think, is most likely a very good long-term parameter. There's nice techniques coming up that we only used in mice with dark field imaging. But that is already applied in patients as well. So I think this will be an interesting technique because they were able now to trim down the radiation exposure quite a bit, which was extremely high in the beginning. But this may be a nice technique coming up. But I think as we are all putting our babies into MRI to get to know how the brain does, I think maybe this is a nice way too. And where I think you can see that if you look at the changes of T1 and T2 relaxation times, they are as well able to pretty nicely distinguish between a baby that has BPD and a baby that doesn't have BPD. But now relaxation times is nothing that is, you know, available in each and every program at each and every center. And so we try to develop a score. And here I brought these images so that you could appreciate that emphysema can be scored in these babies. Interstitial enhancement can be scored, airway accentuation, and ventilation inhomogeneity. And this overall, then, if you have the model pick the variables that make sense to distinguish between controls and BPD, you can see that yes, gestational age is a driver to begin with if you put it in the model. And then interstitial enhancement is a good indicator whether or not the baby has BPD or no. In the more severe cases, emphysema is joining. I didn't show these data here, but is joining and helping with distinguishing the babies. I want to wrap up by saying that I think the matrix does play a role, and this matrix remodeling, I think, in the mice is something that we really need to reconsider, especially if then we shut down one of the harmful players that we think might be playing a role, like elastin. And then all of a sudden, fibrillin, another player, shows up. So there's a huge way of the lung to compensate for changes as well. So that I think we're just at the beginning to understand this. As I said, the forced expiratory volume might be a good indicator, but maybe not the only one. And the angiogenesis related pathways that I showed you earlier that are actually where I showed you the difference between male and female, I think are pointing to the fact that we may have underlying subtypes of disease, airway, interstitial, and the vascular compartment. And there is some markers, but still the agreement that echo is not the greatest way to detect vascular disease. So maybe here as well, MRI might be a good way to detect PA flow and its pathology, because the reviews have suggested that, well, you know, you need a marker that is doing better than echo. So if you do this in MRI, then what you can see is that you have a pseudo increase of volume in the pulmonary artery. And this is because the pulmonary artery is more distended. This is what we have seen in MRI in the BPD babies. This is because of the rarefied capillary bed, which of course you cannot visualize by MRI, but which we think is the underlying cause. And then we do see the entire show, so to say, of afterload, septum deviation, septal diameter, and then a pronounced right ventricle. So maybe by imaging our babies in MRI, we can get hands on these risk factors. If we then stratify our proteomics in plasma, in tracheal aspirate, and in urine, I'm sorry, in urine and in tracheal aspirate, by using this MRI score for altered PA flow, then this is what we get, and this is where I was hoping we can share that pattern. Exome sequencing so far not very successful, and I think this is the reasons, because it's such a heterogeneous disease and there's so many drivers that if you don't account for that, then you find rare alleles, but you don't find something that is really driving the entire panel. And maybe this is because it's not all the same disease. The comorbidities play a role, and I think we have to take into account that we're not only talking about the lung, but that maybe the brain is influencing what we're measuring in the blood too. And for sure, the lung is impacting what happens in the brain. And this has been shown by studies where these inflammatory markers, if otherwise healthy neonatal rodents are actually challenged by these extracellular vesicles, they can induce just the same brain injury with pronounced inflammatory changes as the ones that were directly exposed to oxygen. So I think there is something behind that, and it has maybe something to do with white matter disease. And when you look at the babies that we imaged in lung MRI, when you look at the global network, then you can find a pattern that is very specific for the BPD babies as compared to all the controls. So this is, I think, what you have to take into account then when you take the entire circle, go from this global network, go to the ventilation story, and then go all the way when you then start to stain these mouse brains. You have to say, well, I'm not going to any region, but I'm going to that region that is the anatomical correlate for what we have found altered in the BPD baby. And we have added some intersection analysis from the transcriptome data in mouse brains. And I find that the brain is a beautiful organ too. So this is first the first stainings here, where we try to stain for the factors that are circulating when the neonates are undergoing lung injury. The neonatal mice, and we're trying to see whether the changes reflect whatever the global network indicates from the preterm babies with BPD, and it seems to be the case. I wanted to finish with something that I think is absolutely important, that neonatal hypoxia does more than disrupting alveolar development. I think we have just started to begin to understand what it actually does. And I think the metabolic effects are vast, and we still have to understand this. And they will for sure impact whatever we find circulating and whatever we think is a good biomarker. So even that needs to be taken into account when we look at metabolomic data, when we look at metabolic diseases, and if we look at the potential of cells to recover and to actually derive from the bone marrow that cell that is supposedly then healing the process, maybe not. I thank you sincerely for all the time that you have spent listening to me, and for the opportunity to speak again. And I am absolutely happy to answer questions. Before that, I would like to thank all the collaborators, and there's many more. I just named a few, and the grants that we all have to fight for. That might be one of the students' questions later. Why are you still doing this? Trying to always get the pennies together to continue to do this. I hope I could give you an overview of what we think might be challenging questions in finding biomarkers. And I didn't leave you more confused than you were when we started. Thank you.
Thank you, Anne. That was wonderful. I love the ability to bring together the animal studies with the human and then back again. And I think you really did point out the complexity. There's many people here that are interested in early life influences that prime the lung later, and BPD and oxygen or ventilation. It's just one of them. Others here are studying cigarette smoke and e-cigarette chemical flavorings and a variety of viral infections and stuff. So the theme is well placed.
Yeah.
I want to open it up. I see there's for questions. Gloria, did you have no, she's got to take off. Gloria is saying she's going to take off. So she'll talk to you later. I know we're short on time, but I thought I'd ask you a question that relates to your question. It may frame some discussion for people later. Do you think we need to have a biomarkers over the lifespan? Because the biomarker you find in the child in the NICU may not be the same biomarker you need to see when they're 20. Matter of fact, that biomarker could go away, right? So do we need to have a normative biomarker map to then place against a biomarker map of a change over a lifespan?
Yeah, very good question. I think first thing that we need, I believe, is a chip really that addresses in different combinations of proteins, different diseases that are emerging. So, and that addresses then acute as well as emerging chronic complications. So that would be the ideal situation. And then absolutely, we should redo this chip or this proteomic panel over time and see who drops out and who is still there. And maybe by redoing the entire proteomic screening later, we will find very different markers being responsible then, or being good indicators then. And they, I think they serve as long as they serve, and then we can drop the ball if they don't do their job anymore. As far as I can say from the comparative studies that we have done with the ILD patients and the COPD patients, there is a shared pattern. The only thing that is shared, though, is an activation of the coagulation cascade. So that is something that is that all the three diseases share end stage if you pick the severe diseases. And I think that might be handy because everybody can do it, you know, even in some practice somewhere in the woods. But I think, and it's actually the activation of the coagulation cascade is even adapted for development. So the neonates do it a little different as they, you know, normally do it very different as the adults, but the result is the same. So maybe we need both shared markers that account for adult disease and long-term perspective, as well as the markers that help me for the first 2 years or 3 years or 5 years.
Thank you. Are there other questions? I know we're running over, but I want to give the opportunity for many people to, if they have to, would like to ask a quick question.
I have a quick question. Thank you so much for your talk. You talked about the whole exome sequencing and how that was maybe insufficient to be super predictive near the end of your talk. And I actually had a question about whether you think that was because whole exome sequencing doesn't hold the answers, or whether it was because there were, like you said, so many different causes of BPD that it's difficult for us to differentiate the BPD that results from cause A versus cause B, and whether or not the whole exome sequencing was still useful if you were able to differentiate the different causes of natures of the pathology.
I think GWAS or the tools per se are really informative and helpful. I think that our stratification of the patient is not good enough to really tease out those differences. If we do that by the use of count variables, we might be more successful, maybe not. I think we will, personally, I think we will be successful if we have understood how the interplay as well is, and what layers of second and third hits we have to put on this scenario to then, you know, get one pattern of response and then another. or responsibility, if you want so, of a genetic background. I think we really have to take this apart better from both sides, meaning, and there's as well the ever developing field of genetic interaction that I think we're not accounting for yet properly. So I think, this is meeting in the middle and giving us a very vague result as of now. Because we need to learn to stratify them better. And maybe these disease subtypes can be a way, maybe there's other ways,
Thank you so much.
You're very welcome.
If there's no other questions, I want to give Anne a chance to take a break before we have the training session and have continue the conversation. I want to thank you again, Anne, for giving a wonderful talk, and appreciate your ability to participate in the day with us and share your views. I will, at this point, I guess we will end the keynote speaker session, and so everybody can take a break. And those who would like to log back in at for the training session, I know we have about 20 people or so coming back in. Okay.
Super. Okay.
You have that link, Anne? I don't know if
see
it's
you
the same link off the top of my head, but you should have all that, right?
Yes, I do have everything.
Okay.
Thank
All
you.
right. Thank you, everybody.
I talk to you soon.
Okay. Sounds good. Okay. Man, you're driving me crazy. There's so many things going in my head. Would you do a proteomic screen with me on mice that were old?
Yeah.
I got 2-year-old mice.